Good morning, everyone. Thank you all for joining. And I want to say that we're really happy to have you here today. I'm Sandy Zink, CEO of Lumeta. We're going to follow the agenda in this slide you can see now. I'm going to make a few short remarks and introduce our speaker, Dr. Anthony Dakwar, and he will then give an overview of the upcoming study applying our PDT system in treating patients with colorectal cancer undergoing resection surgery. We'll then open the floor to questions, and please use the Zoom chat function to ask any questions that we'll take in the order that they come in. The upcoming study, as you can see here, the upcoming study will use Lumeta's Digilume PDT system. The system presents a revolutionary new way to administer photodynamic therapy. At the core of the system is novel PDT light delivery, an innovation developed by Dr. Gal Schafferstein, who's also on the call from Roswell Park, and his team, which allows direct monitoring of light interaction with target tissue over a broad area. This enables closed-loop control of light delivery that we leverage in the Digilume system seen here, in which PDT light administration is fully automated, fast, and precise with light delivery. We pair the Digilume system with a compound called 5-ALA, marketed in the US as Gleolan, an approved agent with a known safety profile. Together, this disruptive platform greatly reduces the procedure time and phototoxicity side effects and complexity of legacy PDT, which we believe will reinvigorate broader use of PDT, a proven cancer therapy, into numerous numerous indications. The two currently under clinical development studies by Lumeta shown here are applied intraoperatively in standard of care procedures. In both cases, the precise light dosing of the Digilume system is used to selectively elicit a desired immunogenic or ablative effect. The first applies PDT in treating patients with advanced lung cancer as a combination therapy to amplify the response of patients to immunotherapy. Patients that respond to immunotherapy are realizing remarkable outcomes today. However, the low rate of these patients realizing a full response to immune checkpoint blockade, which is approximately 20%, is disappointing and considered a major challenge today in treatment of lung cancer. Second indication to be introduced and discussed today by Dr. Dakwar applies PDT for treating positive surgical margins in patients with advanced colorectal cancer undergoing resection. Overall, our goal is to present PDT as a patient-friendly, toxicity-free therapy as an alternative to reduce the use of chemotherapy and radiotherapy. Two last slides. An important aspect of this indication and the upcoming clinical study Dr. Dakwar will present is in the use of Gleolan, which will leverage the unique capability of this agent for both diagnostic and therapeutic use with a single compound. As depicted in the figure, after introducing excess 5-ALA, the selective accumulation of protoporphyrin 9 in malignant cells can be exploited as an imaging agent under blue light illumination for increased visualization of malignant tissue during surgery. Gleolan is currently approved in 42 countries for patients with glioma as an imaging agent for fluorescence-guided surgery. Following fluorescence, PP9 can be activated under a different light regime to create reactive oxygen species for cell killing and the therapeutic effect. The study to be presented today is among the first to evaluate such see and treat use of 5-ALA in a clinical setting. It's my pleasure now to introduce Dr. Anthony Dakwar, co-investigator along with Dr. Schafferstein of the upcoming colorectal study. Anthony is a fellowship-trained colon and rectal surgeon specializing in treatment of complex colorectal cancers at Roswell Park. He brings expertise and a focus on minimally invasive, robotic-assisted surgery. Dr. Dakwar, I'll turn it over to you.
Thank you all for joining. It's my pleasure to be able to present this to you. I'm just going to share our presentation here momentarily. And should go full screen here.
And then just back up to your title.
Yep. So just confirm with me, you guys seeing the appropriate screen?
Yes.
Very well. So welcome all. Thanks again. So I'm Anthony Dakwar. I'm a colon rectal surgeon here at Roswell Park Comprehensive Cancer Center. And here in my role here at Roswell Park, I really dedicate my expertise and career towards moving the needle in our rectal cancer world, and especially advanced colorectal cancers. So without further ado, the title of our project is a little bit long-winded, but fairly simple. It's image-guided surgery followed by intraoperative photodynamic therapy for improving local tumor control in patients with local regionally advanced or recurrent colorectal cancer undergoing surgery. It's a phase 1/2 trial. So who we are here at Roswell Park, we are a comprehensive cancer center, and we are definitely an NCI recognized site, so National Cancer Institute recognition. We are one of 19 cancer centers in the country that have this designation. In addition, we have multiple other accreditations from the American College of Surgeons and COC, Cancer on Commission. Specifically in the colorectal realm, we are a colorectal center of excellence per NSQIP guidelines, which we perform at exemplary status with our postoperative complication rates and overall patient satisfaction. We are the first institution worldwide, a little bit of history of Roswell Park, one of the first institutions to have a focus exclusively on cancer care and research of that. Just within the last year or so, we have over $100 million for grants and contracts that we've obtained, over 500 funded projects, and nearly 100 US patents. So a little bit about our overall view here and goal as a cancer center here really at Roswell Park to move the needle forward in cancer care. So to the intentions and purpose of our study, the clinical background is that locally advanced or recurrent colorectal cancers have a recurrence rate from about 10 to 50%. Most commonly, that's attributed to a positive tumor margin. So that local recurrence rate of these cases is bar none likely secondary to a tumor margin. So our current treatments for this include a radical surgery and often intraoperative radiation. The recurrences are clinically important because not only the rate, but the symptomology that occurs with these recurrences are devastating, which include chronic pelvic pain, debilitating neuropathies at times, bowel obstructions, and as well as pelvic floor and sexual dysfunctions. Of note, underserved and underrepresented populations are even more so affected by this because they usually present with a more advanced stage, which can imply a higher recurrence rate. So the idea is that to maximize the utilization of image-guided surgical resection, more specifically robotic. And just to carry on to what was just presented, using 5-ALA or 5-aminolevulinic acid, trademarked as Gleolan, we can improve the detection of these residual cancer cells in the surgical bed. The tumor itself is resected. However, again, the recurrence rates are likely due to the positive margin that is not seen by the human eye. These are microscopic sites of disease that we are literally unable to see with our eye. And we hope to improve that visualization using Gleolan. And once that is detected, we can ablate these surgical margins using PDT or photodynamic therapy with the Digilume appliance. What this has potential to do is significantly reduce not only the recurrence rates, but also the side effects when compared to traditional use of intraoperative radiation therapy, which is not a benign treatment. They have significant risks associated with that we can get into. So with the knowledge that we've obtained about using this platform for malignant glioma as well as malignant mesotheliomas, we like to extrapolate those data points and hopefully use that in the colorectal realm. Just briefly, the study schema as it would be applied. As this is a trial, patients are consented. Preoperative imaging would be obtained in the standard of care fashion for these procedures. We would also be obtaining tumor markers and lab works noted here as ctDNA and CEA at baseline. These are all standard of care. The Gleolan would be obtained and given to the patient day of surgery. The surgery would be performed in standard fashion, and we would then elicit our fluorescence to identify and target the surgery for image-guided resection, and then secondarily use that as well as our marker for our intraoperative photodynamic therapy. After that's completed, we'll do safety check within our 30 days to make sure there are not any adverse or unanticipated side effects due to the PDT. We'd also get further lab work throughout the recovery and surveillance schema, which would be up to 3 years, but at our 3-month mark, would be obtaining imaging. So on the right, you do see a picture of our anticipated robotic procedure with our Da Vinci system. Below that, you have some of the pictures identifying the mechanism and technique that we'd be using for the procedure with the DigiLoom appliance. So the clinical application, if we can take a step back, again, is that recurrences are due to the residual cancer cells harboring the surgery site that are unseen to the human eye. Using a fluorescent to enhance tumor cell localization paired with the photodynamic therapy is not only novel and unique technique, but has the potential to really be groundbreaking in how we treat cancers. And when I say that, I'm talking about the future. And the future is really limitless here because of the known minimal risks and side effects of PDT therapy. The applications realm to where we can be using this is quite endless. In most abdominal surgeries, for example, we do have limitations in where and how we can use radiation therapy for these margin status cancer cases. And that can be applied for liver surgery, abdominal wall resections, retroperitoneal sarcoma cancer sites, and obviously the pelvis, which is what we're trying to focus on in the colorectal realm. The application of this technology and synergistic technique is going to be unique because it's targeted therapy. The disease sites, again, that we can apply this to, once we prove safety and efficacy for the pelvis, the rest of the abdominal surgeries should be even easier to apply because the risk factors should be less, given that the anatomical structures in the retroperitoneum or abdominal wall are less significant. So with that said, I'd like to take some comments or questions so far. Again, I tried to be as brief and succinct as possible to bore you with all the small details, but please feel free to ask any questions or any clarifications. I'm happy to, and thank you for attending.
Thank you very much, Dr. Dakwar. This is Paul Sanders calling from the Lumeta office in Rocky Hill. A couple questions. You mentioned use of intraoperative radiotherapy. What really is the potential for this to replace IRT and why?
So great question. Again, back to these local recurrences in the pelvis, the only real options we have at this point is a radical surgery with intraoperative radiation therapy. Now, intraoperative radiation therapy, number one, has its own limits because you require significant machinery to apply the radiation. Secondarily, the surgery center or hospital has to dedicate a OR room with specialty equipment and built-in walls to use a radiation center. So it's a huge investment from the hospital itself, which therefore implies that this is not offered uniquely and throughout the country or worldwide, as a matter of fact. So one of the advantages just of PDT alone is that this is a transportable system that can be used in any OR, ambulatory, hospital setting, and so forth. So just the utility of it alone is a huge advantage. Now, clinically, radiation therapy, unfortunately, is not being able to be offered everywhere due to the risk factors associated with radiation therapy. Intraoperative radiation therapy can be pretty abrasive. Risk factors are pretty significant for bleeding or injury to the surrounding tissues. Another important fact is the bone density in that area that's going to be radiated. So what that means clinically is that patients that have any signs of osteoporosis or osteopenia would not be candidates for the radiation therapy because of the risk factors associated with bone fractures and so forth after the radiation therapy. So those two alone open up a wide net of potential use for PDT.
Thank you very much. Another question's come in. Approximately how many patients do you see coming into your practice that this technology would be applicable?
So great question. You know, we're finding more and more locally advanced and recurrent colorectal cancers in our population. Just offhand, not off topic, but offhand, we do know that since 2019, the American Cancer Society has lowered the rate of screening colonoscopies from 50 down to 45. And the reason for that is because we're finding more and more often that younger patients are presenting with locally advanced cancers. And because of that aggressiveness, we are finding increased recurrences to that. Now, incidence rate can vary population to population. However, my practice, because of what I do and being at a cancer center and really specializing in this, we do see approximately a handful of patients a month that would potentially benefit significantly from these local therapies.
Excellent. Thank you very much. From a practicing surgeon's perspective of this imaging and therapeutic see and treat, as you refer to it, what do you have in your arsenal to do this today, and is it adequate? And if this was commercially available, this new technology, would it really significantly enhance the procedure?
Yes, no, I believe so. Again, like we alluded to, you know, PDT is pretty transportable and wouldn't require significant amount of preoperative planning, whereas the exact opposite of when we plan to do intraoperative radiation therapy. So I think the application would be much more useful. It would be easier to apply, less planning, which essentially makes it more available to more and more patients. In my actual clinical practice, again, this is what I do and what I do the most. So this would be likely a standard of care going forward once this is up and running for these patients with locally advanced colorectal cancers. I can't describe enough the morbidity associated with these locally advanced cancers and recurrences. The patient symptomology is extreme, and we're really trying to do everything we can to move the needle on these patients and their outcomes. Again, surgical resection has its role and it will stay there. However, we do need an adjunct, and at times the radiation therapy sometimes is not applicable or unable to be used. And secondarily, as an off topic, it does almost force the patient to have an open procedure, which is associated with a significant amount of increased risk factors for open procedures compared to minimally invasive. And this has been proven time and time again since the mid-90s that minimally invasive approaches have much improved outcomes compared to open procedures. So using the PDT technology, we would be able to stay minimally invasive and more essentially robotic, which has obviously been shown to have increased and further beneficial outcomes for the patients.
Thank you for that answer. Next question. Could you have at a high level walk through the procedure, how and when the PDT would be applied? How long do you expect that to take? And does introducing this new technology introduce any new complications in the procedure?
So I'll answer that backwards. Since it has been used already in previous cancer sites, as we discussed in gliomas and mesotheliomas, and also ongoing trial with our thoracic colleagues, the risk factors or complications or planning for the procedures are not any worse off than without using it. The actual schema of the procedure would require the patient to have oral intake of the gleolan several hours prior to surgery. And that illumination or sensitization effect stays for several hours. So we can take it for an actual example. A patient would show up for their 7:30 procedure. They usually show up around 6 a.m. They would be administered the Gleolan. We would proceed with our operation as planned in a standard fashion for someone who was having a rectal cancer. We would do our robotic surgery, which would remove the rectum that includes the tumor itself. After our surgical resection is done, we would then illuminate with our white and blue light to try to catch that variation of the now sensitized residual cancer cells, if any. If so, they would be resected, if feasible or appropriate at that time, and then followed by our PDT therapy treatment. And that has variation amount of minutes pending on the intensity and light variation that we identified during the procedure. Once that is said and done, we would complete our surgical closure as standard of care, and the patient would recover. Patient would be monitored in our clinical trial patient setting significantly for their next postoperative course while in the hospital, and then obviously followed for months on out, up to 3 years postoperatively for evaluation of our long-term outcomes. So the technicality aspects of it do not change our normal standard of care. We're not really making any special or significant changes in order to apply the PDT, or it's pretty able to be streamlined in our protocol as we have right now. So feasibility and ease of utility is definitely a very positive option that we have for us.
Very good. Thank you for answering the question. Next question, referring to the upcoming study. When do you expect, what's the schedule for this? When do you expect to open up the study? And also you have some biomarker being taken during the study. Is that going to be used in your efficacy assessment?
Yes, correct. So so I don't forget your two questions. So the first one is that we are finalizing our protocols now and making sure all our paperwork is in line to hopefully start our project in the beginning of 2024. I say that potentially at the end of the year in December, but realistically, to be safe, January 2024. And secondly, your question was, I forgot already.
The biomarker
Yes.
data, is that going to be used for efficacy assessment?
Yes, so CEA is a tumor marker that is used for the last several decades now, or 2 decades or so, as a tumor marker. It does have its limitations, and we're using standard of care for surveillance of patients and identifying preoperative states. It does have its limitations as not all tumors elicit or produce CEA. So over the last 5 to 7 years or so, there has been major developments in using ctDNA as a marker for presence of tumor and also for surveillance of it. We use this routinely in our survivorship patients and our surveillance patients as a marker of potential recurrence or residual disease. So that, yes, will be used in our standard of care as we do today and will be applied to our trial patients.
Excellent. Thank you for answering the question. Next question, you mentioned robotic assisted procedure. Would that be also applied during be used during the PDT procedure, and how?
So great. So, and part of the novelty in this project is not only the use of targeted therapies, but secondarily to do this in a minimally invasive approach. I'm a very experienced robotic surgeon. That is part of why I'm here to further expand the robotic program here at Roswell Park. And secondarily, the robotics is by far the majority of our practice. So in that, we have developed a way where we can maintain our robotic approach and use the PDT, and we would do this by utilizing various abdominal access ports where we could place the PDT applicator through and use that to treat the intended area. All of this while maintaining our minimally invasive approach, our robotic visualization, which is pristine compared to an open or laparoscopic historically, and allows for truly targeted therapy under robotic visualization. That is a key point to this project in not only furthering PDT therapies, but also moving away from intraoperative radiation therapy, as I said, has forces us to perform an open procedure.
Very good. I think that's the last of the list of questions I have. I open up the floor. Anybody want to continue feed through the chat, or just unmute yourself and ask questions? Okay. Sandy, do you want to wrap it up?
Yeah, Anthony, thanks so much for answering those questions directly and really well. And there's so many unique aspects to what you're doing here. Thanks a lot for sharing and for keeping it, as you said, concise and targeted in your presentation. So thank you. And folks who signed in to join us, really appreciate your participation, your questions. We think this is an exciting study, as Dr. Dakwar has gone through, and we're really looking forward to getting started. And we'll share more information when we have it. For any of you who want to get a copy of what we have done here, we have taped this presentation, and we'll send it out to you and those who couldn't join. And I'll just end by saying, Anthony, thank you very much. And Paul, thank you as well.
Thank you very much. My pleasure to be here.
Thank you for the invite from Ascension Healthcare. We really appreciate it. It was very informative, and we've gone to a lot of our sites, and I don't know if it's just because it's in still the early stages of development, but I think it's something we certainly are going to be watching, and hope to stay, really in touch with this study and the progress that it takes.
Thanks very much.
Very good. Thank you so much.
Thank you. Bye-bye.
Okay, have a good day, everyone.
Thank you. You too. Bye-bye.
Bye-bye.